Hello, everyone. Good day. You are welcome to today's Public Health Faculty Development course on climate change. In today's session, we are going to look at climate change, air quality and health, risks, vulnerabilities, and solutions in 2025. So for English captions, you can click on the CC link button below. And for Spanish caption, please click on the link in the chat. So for today's course, we are going to look at the climate change, air quality, as I said earlier, and the main objectives for today's course would be to explain how climate change exacerbates air pollution, including its effect on ozone level, particulate matter 2.5 and below, toxic smog, and respiratory irritants. We also describe the health impacts of air pollution on climate-sensitive diseases such as asthma, chronic obstructive pulmonary disease, cardiovascular disease, and also identify populations vulnerable to degraded air quality, considering factors like socioeconomic status, geographic location, and pre-existing health conditions. Also look at the evaluation of public health strategies to reduce air pollution exposure, including individual protective measures, early warning systems, and outdoor activities on poor air quality days. We will also examine city-level and regional interventions to mitigate air pollution, including nature-based solutions, public health transportation policies, and cross-border and cross-sector cooperation on risk reduction. And finally, we will also analyze the near-term health impact on mitigation efforts such as improve air quality and reduce respiratory diseases. We are going to have 90-minute sections with 30 minutes lecture and 15 minutes case studies. So we would have 3 case studies, 15 minutes each, and there will be questions and answers after all the presentations have been made. Kindly put in your questions in the Q&A section, and please don't put it at the chat section. To view the recordings, you can go online, and this will also be accepted as an attendance. If you are not able to attend the online section, you go online to view the recorded documents, and this would also help us to finally give you a certificate, which would include attending 8 of the 11 courses, and also your exam score would also be a factor in determining whether you get a certificate or not. So to join, you can join us via WhatsApp, and this will also help you to get important course information and also reminders to the various courses. You can scan the QR code shown, and this will link you to the WhatsApp group. Thank you, and please let's get ready for our first presentation, which will be a 30-minute lecture by Professor Leon Go. He is a distinguished professor in the Environmental and Occupational Medicine section of the National Taiwan University, and also a physician in that hospital. Thank you so much, and let's enjoy this course and get more information to improve climate change in Africa. Thank you.
Thank you, Marian. Let me share my screen.
This is the small step together. Everything. This is now. This is the warning.
Okay. Thank you. It's a great honor to be here. And I'm actually a faculty in medicine and a faculty in public health in National Taiwan University. So I think this is very relevant for me. Do you see the full screen?
Yes.
Okay, wonderful.
Yes, we can.
Um, okay, you are very familiar with this one, so I will skip. I just want to say that the um, climate change will affect air quality from many aspects, but I will discuss from the chemical and biological as some of the important events. The air pollutants from human sources include primary pollutants and secondary pollutants. The PM, SO2, CO, NOx, PAH. Sorry, let me try to see if I can use. You don't see my mouse. Sorry. Okay, I will just stay with this one. So PAH and VOC and secondary pollutants include ozone, particulate sulfates, and nitrates. And the reason to call it secondary pollutant is that from NOx and the VOC through the sun heat, they will become ozone. It's complicated, so I try to minimize the memories needs for this one. So CO and NOx belong to the traffic related uh, pollutants. And PM is from complex sources, but carries more health effects. And the other one is the oxidants, mainly from the ozone. So if you look at the three things, you probably know most of the air pollutants. PM, SO2, CO, NOx, and the ozone are monitored by many countries using automatic monitor. Therefore, information on the health effects are more available at this moment. There are impacts of climate change on air pollutants, and direct increase in temperature will increase the air pollution, and mainly on the ozone and PM 2.5. The climate also gives you stagnant weather conditions, desert dust, and transboundary pollution. They also increase the allergens by pollen or fungi. And the events of wildfires also cause acute increase in PM and VOC. So these are the possible mechanisms that climate change can affect air quality. So in the ozone, you know already the sunlight to be a very important factor for the occurrence. And increased heat induces the reaction higher, therefore increase the ozone. PM, the heat would increase the VOC emission from natural and anthropogenic sources and causing increased chemical reaction and causing higher secondary PMs. One of the example being that the increased temperature in LA and other areas in the US is highly related to the maximum daily ozones. So with a higher temperature, the ozone can be a problem in those cities that are having higher risk of ozone exposure. The air stagnation is a meteorological situation in which, look at the right side, the warmer air acts as a lid and holds cold air near the ground. So the pollution cannot be easily cleansed, and the buildup of smoke, dust, gas, and other air pollutants cause health outcomes. So when there is air stagnation, an advisory will be released by the National Weather Service. From some studies, it is known that the rising temperature will increase the stagnation, and the two pictures show the end of 20th century and the end of 21st century. You'll see in many regions, air stagnation becomes more problematic. Desert dust is also from temperature and shifting precipitation pattern, reducing soil and increase deserts. And if you like to know, the total dust emission from the deserts contribute to about a half of the total tropospheric aerosol, and is a very huge contribution worldwide. And that can be um, transboundary to very far places. So the Asian stone goes to Asian dust storm goes to Japan, Korea, and even to the U.S. and the Arctic. So it can be a very far-reached health outcome as well. It's estimated that from the beginning of 21st century to the end of the 21st century, the overall dust mass will be increased. Let's take a look at some of the health effects related to those pollutants, and mainly the ozone and PM. This is a study carried out with Taiwan, Korea, and Japan. And you will see the daily mortality to be increased with the ozone level. And it looks like 40 ppb is a key ozone level, where increase in mortality became significant. What happened to the PM 2.5? This is a study made possible by many countries, 652 cities. It's called MCC study. And combining all the data, it's possible to find out that the daily mortality relationship with the PM 2.5 concentration becomes a curvilinear. And so with improving PM 2.5 level, reducing PM 2.5 level, the mortality is improved. And there seems to be no threshold in this regard. And therefore, the WHO had an interim target at 75, drop to 50, drop to 35, and in 2021, they dropped to 15. And the further dropping of the target will not surprise me. However, it's getting more and more difficult to reach. So who are most vulnerable in this study? The elderly, those with chronic conditions, especially cardiovascular and respiratory diseases. So not only the day-by-day effect, but also the longitudinal effects can be seen with PM 2.5. This is from a summary of the Global Burden of Disease study. They came up with a relative risk of lung cancer, ischemic heart disease, stroke, COPD type 2 DM, and low respiratory infection. And they take the non-threshold approach. So 0 is relative risk of 1. And with increase, you'll see increase in the relative risk. So these conditions can be improved if the PM 2.5 is reduced. The other health effect is asthmatic attack, which is known to be associated with particulates and probably also related to other pollutants as well. But there is an asthmatic attack associated with PM increase. The other effect, PM exposure, was associated with increased art ratio of congenital heart disease, neural tube defects, cleft lips. So the most important exposure period is in the gestational period when the target organ develop the most, and that period becomes the critical period of time of exposure. So if you plan to go for an international travel, please know your potential pollutant exposures. So there are quite a few websites that tells you what the overall situation last 1 week, and some also provide the forecast as well. There are another IQ Air, another website. One important condition related to climate is allergic disease. So it is known that increased temperature are related to asthma and allergic rhinitis occurrence. And there are potentially health effects caused by the increase, but direct exposure to heat, extreme heat, will cause the allergic disease to occur, to attack. But there are also air pollutants like ozone and PM. There are also flood that cause um, um, biological growth or microbial growth. There are fungi growth in outdoor as well as indoor, and there are pollen that's potentially allergenic. So it's not easy to carry out a study for long-term climate change effect because you have to have an assessment 20, 30 or 40 years ago, and you have to have the same assessment now. So mortality used to be a very common outcome. However, this is a study that carry out 27 years of study in Western Liguria in Italy. They show increasing temperature as well as the days of temperature greater than 30 degrees centigrade. As a result, the duration of pollen season were increased for several of the allergenic pollens. Also, the total pollen counts were increased. And as a result, the percent of sensitized people were increased to the allergenic pollens. And this is a very strong evidence that the pollen and the sensitization are affected. The fungi there are quite a few allergenic fungi as well. And the fungi, we conducted a study a few years ago and look at the year-round fungal spore count. And you will see that in June, July, and August, total fungal spores were highest. And if you look at the effects from temperature and relative humidity, they are both important contributors to the fungal spores. And as you can tell that increased temperature might be an important factor for increasing fungal spore. If you look at only the outdoor air pollutants from VOC or other pollutants actually can penetrate into the homes, the indoors, very much through a window or other penetrations. However, there are also indoor sources like a VOC and indoor particles. So it is known that indoor air can be linked to heart disease, respiratory disease such as asthma, and even some cancer. However, there are biological agents that become more and more important in indoors, like mold, dust mite, bacteria, and other pollutants. And something like flood damages can create a damp indoor and lead into mold growth, as exemplified by Katrina hurricane. It is known that atopic dermatitis is related to mold growth. This is a study that looked from the Taiwan birth cohort study, and it shows that wall fungus is related to atopic dermatitis. So the homes with wall fungus have about 45% increase in the children's having atopic dermatitis. And the condition is actually quite relevant because quite a few homes have indoor fungi. Fungi is known to have some effect on lung function. This is study on school children. And at the level of fungal, the cladosporium spore of 1,500 spores per cubic meter, you will see a drop in lung function, including vital capacity and FEV1 in the children. So the other important thing is the vulnerability of the recipient. So to have an environmental risk, there must be natural hazards. The people need to be close to the exposure site, so they are exposed. And vulnerable people are more likely to develop health outcomes. In public health, what should we be concerned? For example, this is an IQ test in 6-year-old, and these are unexposed, and the black one is the exposed children. And you are concerned when there is an overall shift in IQ. However, the small percent of susceptibles, initially, for example, only few people belong to the lower IQ group. However, the exposed people may become many times. So more people will become disadvantaged or unhealthy in this regard. So these are very relevant in health issues in climate change and air pollutants. We need to take care of the overall shift and the susceptible people. Using this as an example, this is related to allergic and the asthma. The climate change have several factors causing the exposure. However, who are susceptible? For example, those with atopic eczema with epithelial barrier defect have a much higher risk of developing asthma. There are also social economical factors. So the elderly, those with CV disease or respiratory disease, those with susceptible ages, the infant and children, pregnant women, those are also disadvantaged in socio-economical conditions like a low education or low income. And a large group is also the outdoor workers who are highly exposed and cannot avoid, um, cannot hide from the heat or from the climate or the air pollutants. So vulnerable people have to be considered when preventive strategies are developed. So let me talk about a little bit on wildfire. So increased temperature will cause the dry out the vegetation, and the strong wind will spread fires, and the change in precipitation factor will reduce moisture in the forest, and extended fire season and also increased lightning are all the factors. Although these conditions are varied in different regions, let's take an example from a recent wildfire event, which is the LA area in California. So they suffer from prolonged dry period. They have this strong Santa Ana wind. They have highly flammable vegetation. However, they also have other factors like urban expansion. It's actually putting people to the dangerous zone, the wildfire zone. And they also have a lack of water at that point. So wildfire is definitely causing visible smoke. This is from a website, the Copernicus website from EU that shows clearly the smoke. A study just came out from JAMA, which showed that the deaths, the mortality attributable to California wildfire during that period is 6.9% of all mortality. So that is a important contribution to the death. So this is a global fire monitoring condition that showing that actually we are still quite susceptible to the exposure to wildfire. So I had a chance to visit the Australia site of the Black Summer bushfire. Actually, later I was not on site. So these are the satellites showing the fire. You see that it's actually not that far from major cities like Sydney or Canberra. And those people who are exposed, if they are pregnant women, they are infant or young children, or they are carer of the infant and young children, they are at high risk. One study looked at the caregivers and they compare the highly exposed and other. The higher exposed caregivers are more stressed and have more difficulties to be patient with the children and struggle with anxiety. What happened to the children? The children are not wanting to be put down, they want to be held. They want the caregivers to hold them and want more of the attention and not wanting to be separated from their parents, and they cry more. So the children were somehow psychologically affected as well. So this is a site that I visit after a while, but it's still clear that the trees were not burnt and burnt on the left side. So you will see how close you can be with a wildfire. So due to that fear, fire-resistant community hall and bushfire refugee was built near the Budawan National Park, like this, featured what huge water storage tanks, food and life requirements, first aid kit, and they also install HEPA air filter to help them survive the wildfire in the future. Isn't that actually frightening? So adaptation has been um, a big problem and not totally understood. So what are known to be effective is still remain to be determined clearly and to be determined in each locality or regions. There are possible effects, for example, alarm for heat or air pollution, and school children staying indoors to avoid the heat or air pollution, and they reduce the physical activity. The workers with a heat acclimation and resting period, shelters to be built with cold air and personal protection and so on. But each locality need to determine what's needed and what's efficient. So when and how to alarm and which individual and public measures are effective remain to be determined in each locality. And from the public health point of view, educate the public, the students, and the policymakers about the hazard of climate change and the air pollutants induced by climate change is very important responsibility of the public health faculties. Talking about adaptation, this is a figure from the China Times describing a very hot day. You can see quite a few people have good adaptation already. However, some people were not. This one may have limited space to go to. They do not have the strategy, or they are rushing to the work, so they are unable to avoid the heat. So this says about the adaptation difficulties. This is the final slide. If you haven't visited Taiwan, this is southern Taiwan. This is Taipei 101 in Taipei. And one of the important things is that in Taipei Metro, there's frequently open courtesy seat despite rush hour. So with that, I would like to thank you for your attention, and I hope you can visit Taiwan if you haven't. Thank you very much.
Thank you so much, Professor Gil. Kindly put your questions in the Q&A section. And this is very insightful. As we are learning, we have to also think of how we are going to incorporate this into our public health curriculum so that more would be done to help mitigate this alarming effect. Slowly, climate change is going to destroy us. So let's all try and push for it to be taught in the various public health institutions. So we are going to have the case studies. They are going to tell us some of the interventions they've put in place to reduce this harmful effects of the climate change. We are going to learn a lot from them. So we will have the first case study by Professor Tariq Ben Mania, who is also a professor in epidemiology at the University of California, San Diego Scripps Institution of Oceanography, where he leads the Climate Change Epidemiology Lab. Thank you, Prof. Gil. We shall have Professor Tariq. Thank you.
Thank you so much. Thank you so much for your invitation. Thank you so much for being here today. And you should be able to see the good screen. Can you confirm that, Marian, that you can see the slides correctly?
Yes, I can see your slides.
We are
Excellent.
seeing your version, Tariq. You
sorry,
need to switch.
sorry.
Yeah.
Okay.
Yeah, it's not in the presentation mode.
Okay.
It's good now.
So it should be fine now. I'm just going to put a timer just to not be too much behind. So yeah, so thank you so much as well, Professor Guo, for the introduction about the links between climate change and air pollution in general, and also the trying to understand also the implications for population health. So in this specific case study, I wanted to talk about one of the solutions and interventions that we can think about, and I will focus on city alerts and warning systems more generally and explain just like where they're coming from, what's the rationale, how they work, and I will present a few examples. So I'll focus on one case study, which is about smog or air quality warning system in Toronto, in Canada, and just explain you how we conducted its evaluation, like the evaluation of the effectiveness of this program on population health. And then I will just like generate a little bit of conversation about how we really need to combine short-term interventions to more long-term and sustainable interventions. So I will talk a little bit about why this is very important to consider both and not only focus on this kind of short-term solutions. So first, and that's actually important for what I will be talking about later, is that as it has been mentioned before, so we know a lot about the health impact associated with different types of air pollutants in a short-term way. So when, for example, there is a fluctuation from day to day in terms of PM2.5, tropospheric ozone, etc., and different types of health issues, including like daily mortality. So there is a lot of evidence about how this kind of like increase in PM2.5 is going to be associated with an increase in daily mortality in a given context. And we also know for long-term exposures and chronic effect, there is like very, very abundant evidence about how being exposed to a high level of PM2.5 for many years could lead to the incidence of different types of chronic diseases and premature mortality. So when we're interested by this kind of estimating this dose response, we actually typically identify a linear or log linear relationship, and there is also like no safe level. So there is no like level of air pollutant that is not associated with some kind of an increased risk in a given health outcome of interest. So when we think about just like this dose relationship, this is very important to keep in mind, and I will go back to that later, because it's also important, and this is probably something you're familiar with in a public health perspective, because we need to think about the relative kind of risk, but also the absolute level of risk about how many people are going to be exposed and what will be the actual burden. And that's something that will be very important. So when we talk about smog days, this is not a very well-defined concept, scientifically speaking, but typically we relate to smog days as days with extremely high level of air pollution that could be driven by multiple contexts, including atmospheric inversions, etc. But it's very important to note that when we think about these extreme days, this is only the tip of the iceberg, because most population are exposed to a level of air pollution every day, and all of these everyday pollutants will have an impact on population health. So that's very important for what we're going to talk about today. But at the end of the day, all of this epidemiological evidence is designed to inform what we can do about it and what type of interventions we can think about. So there are many ways which we can think about what can we do to reduce the burden attributable associated with air pollution, whatever type of air pollutant we can think of. And we can classify them in different ways, but one way to classify them can be done from this recent publication by G and colleagues. And they basically just like considered like national and international interventions, such as big legislation or the WHO recommendation, even if this is not technically an intervention, it's just a recommendation, but some kind of guidelines to try to reach. But you have different types of intervention, for example, banning lead in gasoline and this type of actions will have an influence on the amount and type of air pollution that people are going to be exposed to. Then you can think about more local interventions that would be at the community city level. And there are different types of approaches. And today I will mostly talk about air pollution early warning system or air quality warning systems. There are different names, but I will use different terms. But at the end of the day, it's exactly the same thing. There will be a level of air pollution that will trigger a set of actions, and people will have to adapt their behaviors. There will be a lot of changes that I will describe later that are kind of expected to reduce eventually the burden attributable to specific air pollutants. You can also think about low emission zones, and I will talk about that later, which are just areas in which some type of vehicles are going to be prohibited to get into a specific city. For example, if we think about in Europe, this is something that is very widely adopted. And in Paris, for example, in France, there is a low emission zone. And the idea is that some vehicles that are considered to be highly polluting are not going to be allowed to get into the city. So that's also is kind of designed to try to reduce emissions and concentrations of air pollutants and eventually the health impact associated with them. And then we can also think about individual level interventions, such as having an air purifier at home, which can be quite efficient for aerosols, for PM, for example. Wearing a mask, like FFP2 mask, can be very efficient for specific types of particles, not too much about gases, but for particles and aerosols, it can be useful, and other types of interventions, including behavioral intervention, and I will talk about that later. So this is basically just how we can think about what can we do. We know that air pollution is just a big issue in terms of public health, and then the question is what can we do to try to reduce the burden associated with it. So one very important kind of information that we can use to actually guide this type of intervention is really about what will be the kind of pollutants that we need to focus on and what will be levels that could be considered as a target. So we have the air quality standards that I implement that are vary from context to context. And the idea is really to have some specific guidelines about what levels of air pollutants for both daily exposure and annual exposure that are supposed to protect as much as possible the population. So but when we think about the kind of short-term guidelines, for example, let's look at the last kind of recommendation from the WHO, and we can see that you have a few pollutants that are being kind of included in these guidelines. And we can think about PM2.5, PM10, ozone, NO2, SO2, and carbon monoxide. So if we think about PM2.5 as an example, we can see that from this last and most recent WHO guidelines, we can see that the guideline for annual long-term exposure to PM2.5, it will be 5 microgram per meter cube. And for daily levels of PM2.5, the guideline is set to 15 microgram per meter cube. As it has been shown in a previous presentation, most locations are going to do not meet these guidelines yet, but that's the goal. It's the goal of these guidelines is really to set up a target for many jurisdictions to try to achieve or to get to these specific targets. But if we focus on an acute exposure or short-term exposure for acute health effects, we can think about these specific guidelines that could be useful to trigger specific type of actions, including air quality alerts. And when we think about just action specifically about PM and PM2.5, it's very important to also kind of contextualize and think about some very important limitations in how this type of intervention and how this type of policies are designed. First, as I mentioned before, there is no safe level of exposure. So any exposure to air pollution is going to be associated with a given risk. Of course, the higher the exposure, the higher the risk will be, but there is no safe level of exposure. So these guidelines or these thresholds are useful, but they're not enough to fully protect populations. And that's very important if you consider all of the drivers of potential heterogeneity in this health effect, because first, of course, not all communities and subgroups of the population are equal towards the potential harmful effect of PM2.5, for example, because there are a lot of reasons for which, for example, people living with chronic conditions may be more susceptible to the impact of the same concentration of PM2.5 that people living without this chronic condition like asthma, COPD, etc. there is a lot of evidence showing how socio-demographic characteristics are also going to make some communities more susceptible to the harmful effect of air pollution, and so on and so on. So it's also important to consider that all of these guidelines do not consider this differential susceptibility across communities. So the first point, and also when we think about PM2.5, this is just like aerosols defined based on the size of this aerosol according to how far they can get into your body. But there is no distinction about according to the PM composition and the source of emission. And there is in a previous presentation, there was this discussion about wildfire and wildfire smoke. And there is more and more evidence showing how wildfire smoke PM2.5 is actually way more toxic than PM2.5 from more traditional sources like traffic, for example. So all of this regulation do not take into consideration this diversity of emissions. So that leads me to how can we try to address that in a short-term way? So there are many jurisdictions worldwide that implemented air quality alerts, which is the idea just when there is a specific level of pollution that is reached, that will trigger a lot of local actions. So this is just a few pictures about what it can look like. This is LA during a day with very high level of ozone. So what happens during these days with an active warning system? So this is a very simple way to kind of summarize the type of action that could be implemented. So we can think about individual actions that are recommended as part of this policy through different medias, through different type of community centers, etc. But the idea is to modify your activity, for example, to stay indoor, to do not engage in active physical activity, to wear a mask, to activate your air filter if you have one, to take some preventive medication if you need to, and to also reduce your emission by reducing your mobility, for example. But you also have some kind of community actions, governmental actions, including closing schools or closing specific type of industries or reducing the speed limit in some jurisdictions, etc. So this is really what happens when a jurisdiction is going to activate an air quality warning system or air quality alert. Okay, so all of these actions at the end of the day are aiming at reducing emissions, the concentration of air pollution, and also reducing the potential harmful effect of these pollutions, such as just wearing a mask or so. Okay, so that's really the main idea. So I want you to talk a little bit more about wildfire, but I will skip that. So because just to make sure I have enough time to go through the specific example I want you to talk about. So this type of air quality alert system are implemented in many places, many cities globally. But I wanted to take this example because it's coming from a study we published a few years ago in which we really wanted to evaluate, does it work? Does it make a difference? If we compare the world in which we have this warning system to a world in which we do not do anything, does it make a difference? Does it protect populations? Does it reduce the number of hospitalization and premature mortality, for example? So we're going to focus on Toronto. So in Toronto, there were this warning system, this type of policy starting in the year 2000. And the goal, as I mentioned before, was to reduce outdoor activities, to reduce emissions from different sources, including from traffic, to close schools, at the end of the day, to protect population from the harmful effect of air pollution. Okay. So the way it works is instead of focusing on one pollutant, it's focusing on some kind of index, an air quality index that combines information for PM2.5, NO2, and ozone. And from this index, as soon as the air quality index is going to be above 50, this air quality alert is going to be triggered and all of these actions are going to be implemented. So just to give you an intuition about how we did and what we call the identification strategy to try to evaluate the effectiveness of this program, we actually exploited this kind of randomness of this criteria of 50, because as I said before, there is no safe level of air pollution. So 50 can be considered to be a little bit arbitrary because it doesn't correspond to any known biological mechanisms. There is nothing specific biologically that happens after 50 that doesn't happen just before 50. So this is exactly what we exploited. So days slightly above and days slightly below this value for the air quality index are supposed to be very similar. And in a world without this policy, this is what we should expect, just this kind of very continuous kind of increase in a risk of being hospitalized, for example, if you take this outcome. But if this policy is that picked 50 as a specific threshold is actually make a difference, this is what we should see. We should see discontinuity in those response relationships coinciding with these specific criteria. So that's really the idea. And this is what we use to evaluate to which extent this specific policy has been effective. We call this approach a regression discontinuity. And this is what we found. So we found that here, here in blue, we have the number of cases for each specific outcome that was happening in non-eligible adults. So they is just below the threshold, so not eligible to the policy. And in red, or kind of purple, we have this value, but on days slightly above this threshold, so eligible to the policy. So here, for example, if we focus on cardiovascular diseases for mortality, we don't see any difference between days slightly above and days slightly below the specific threshold of air quality index equals to 50, indicating that this policy doesn't change the risk of dying from cardiovascular diseases. But if we look at asthma in terms of emergency department visit, we can see a slight difference, where we see that the number of asthma cases or emergency department visit for asthma reasons is reduced in days slightly above 50, which indicates that this policy may have some benefits for this specific type of outcome, but we can see overall that it doesn't make a huge difference, unfortunately. So here, this is just in this specific example, and there are many examples like that showing that air quality alerts may have a limited impact on public health. But what I wanted to emphasize is that even if it was the case, and I will show you a successful example on the next slide, but even if it was the case, it's very important to go back to this very important concept in public health, that because there is no safe level of exposure to air pollution, we have this kind of log linear dose-response relationship between the levels of air pollution using the air quality index or something else and a specific health outcome. We focus on the very, very extreme days. And even if this policy were effective, it would focus on not on a minority of days and a minority of the total burden attributable to air pollution. So this is just to say that even if it was effective, it would not be sufficient to protect population for air pollution in its entirety. And here, this is just a successful example. This is like another program in Paris in which we evaluated to which extent the early warning system for air pollution in Paris was successful or not. And we found that actually it was very successful, like it was very effective at reducing premature mortality. But my point is really that when we think about protecting populations for air pollution, most of the jurisdictions are going to focus on these like extreme days, on these kind of days with very high level of air pollution, like smog days or peak days are different names, but most of the jurisdictions are going to focus on that. Even if sometimes they're effective, like what I showed in Paris, sometimes they're not that effective, like what I showed in Toronto. At the end of the day, this is not enough. It's very, very important to combine these short-term strategies with long-term strategies, because at the end of the day, most of the burden from air pollution is driven by these kind of days that are not extreme because they happen so often. And this is really what I wanted to emphasize, and that early warning system for this kind of extreme days can be effective sometimes, that it can be improved, but at the end of the day, it needs to be combined with different types of long-term strategies, including like different types of like banning on specific sources, but also low emission zones as a specific example. So here, this is just another example coming from Paris, because we conducted an extensive study on this type of issues in Paris. And here we showed to which extent the implementation of the low emission zone in Paris led to substantial benefits in terms of reducing mortality and asthma. Here, this is just to show the spatial distribution of deaths avoided because of the low emission zone. And here, this is the number of asthma cases avoided because of the low emission zone. So we can see also some important spatial distribution, heterogeneity in the potential benefit. So this is really what I wanted to emphasize today, is that air pollution is a big public health problem. And if we want to actually reduce this burden, there are different strategies that we can think about. And you have these strategies that are dominant across jurisdiction globally, that are focusing on these extreme days. They may be effective, but in any case, they won't be sufficient. So they need to be combined with day-to-day activities that will reduce this kind of low kind of contributing, but very like at the end of the day, it will drive most of the burden attributed to air pollution. And low emission zones can be an effective strategy, especially when traffic contributes a lot to air pollution levels in a specific jurisdiction. So this is just an example from like some work that has been conducted in the US to show the effectiveness and the benefits of like this national air quality, national ambient air quality standards designations in the US, which also is something that we can see in terms of long-term strategies to reduce the burden of air pollution, just to show that it can be effective. But the bottom line, just to show that there are many strategies that we can think about, and that can be effective, but they really need to be combined between the short-term strategy and the long-term strategies. So this concludes my presentation, and I hope it was clear, and I hope it was also helpful, because we know what to do. There's different strategies that can be effective, but we just need to do not focus only on the more extreme days. This is not going to be enough to protect population for air pollution. So thank you very much for your attention, and I guess we'll have some time for questions later. So thank you.
Thank you so much, Professor Tariq. We really need an integrated effort to reduce this air pollution. So we are going to have our second case study by Professor Diana Castaneda, who is also a professor in civil and environmental engineering at the Universidad del Norte. Thank you so much. And Professor Diana, kindly share your intervention with us.
Thank you, Mariam. I will try to share my screen. Please tell me if you can see it right now.
Yeah.
Can you see it, Mariam?
Yes, I can see it.
Okay, thank you very much. Thank
Thank
you
you, sir.
for the invitation, Marianne, and the opportunity to present this study case from the city in Barranquilla, Colombia, that is located in South America. I am a professor of the Universidad del Norte, and I will try to explain all the work we have been done, not just by the university, but all the stakeholders, including the WHO, which I am a part of the group expert. So today I will try to explain to you the urban strategies for air pollution reduction, including nature-based, public transportation, policy interventions, and the most difficult part, the collaboration with other sectors that we have been done, beginning with the academic area that I am part of. So I will try to explain that traffic pollution is the most important pollution, or it is the most focused here in the urban areas, because they contribute up to 25 up to 40% of the concentration of mostly all polluted, including the most toxic ones. But if you're talking about CO, for example, it contributes like 90%. And when we are talking about heat, we can see that it surrounding air can be like 4 degrees more compared, for example, to asphalt. So in this city, in this study case, we did a first study when we related NO2 concentration, and we see that in the most traffic, or in the area where we have more traffic, we have more NO2 pollution, and of course, all the other pollutants that come from traffic. When we talk about traffic pollution, we see that vehicles can contribute up to 70% of all air pollutions. And the solution had to be analyzed that in this city, for example, this study case, everybody wants to use a private car, the private transportation use. And a private car, maybe it pollutes less than a bus. But if you want to see how many cars are replaced by this bus, we can see that the pollution is less for a bus. And this part of the urban strategy has to focus on people. They need to use sustainable transportation systems. So the urban strategies we can talk, there are these 4 principles: the transport infrastructure, the nature-based solutions. But of course, we need to do some changes in the built environment and the urban infrastructures. We need to use urbanized use and mixed use to have a city that you have the 15-minute time. You have everything near, so you don't need to use the car in order to go to the school, to the work, or to buy some stuff. And that can be a part of the transport infrastructure too. It's not just to have bike lanes, walkable streets, or improve technologies, but give people the opportunity to do all the things in a 15-minute time. And of course, the sustainable buildings, because if we reduce energy and water consumptions and we do wastewater treatment in these buildings, we reduce some gases such as methane and CO2, for example, because we reduce these energy consumptions. So the first part is the built environment. As we can see here, Barranquilla is located near a river, and the sea is here in the northern part. And we can see there is a zoning. We need to locate the industrial zones away from residential areas. Sadly, this is the industrial area from the city, and we cannot change that right now. And we have some port here that has the emission from the ships, and it is very polluted. The other solution that we have to analyze is the building distributions, so ensuring a preparation layout of buildings to optimize not just land use, but natural ventilations. And it is some things we can improve in this city. The other example is to use nature-based solutions. We need to use barriers, use of vegetation belts, walls, acoustic sinks, trees, parks, and another nature-based solution. Of course, we need to analyze that a tree or a plant absorbs all the particles, absorb the noise, and another pollutants. So part of the nature-based solution we have done here in the city, we wanted to analyze which was the effects in the health and the economic, of course, effects too. And finally, the transport infrastructure. We wanted to analyze how is the traffic managed, how the public transport incentives have a health effect, how people that are using the bike or are not using the private car have better health because of that. And of course, Barranquilla has a very strong politics in reduction of sulfur content, because in Colombia we have a sulfur content really low, and the promotion of alternative fuels too. We can see here the new buses the city just bought. Here, so they use alternative fuels, and those alternative fuels can improve air quality inside the city. So here we can see that our case studies is Barranquilla. The PM 2.5 is hopefully 70 micrograms per metric cube sometimes, but in the mean concentration is 14.75 for the Scottish case for 2022. That was the year we wanted to analyze. And we used some tool of the WHO and the PAO organization too. We use it, this one, maybe you know it, is the ErcoPlus. The ErcoPlus has the standardized method describe it and was developed the health risk assessment inside this tool. I am an environmental engineer, and I don't know exactly which is the inside of this tool, but I know the air quality, and I know the station, and all the data, and we obtained that information from the local authorities here. So it was very transparent for them that we use data for obtained by them. So the concentration response function from the meta-analysis was requested by the WHO to update the AQG, and we selected that for the first study case. So the city of Barranquilla have many local stations, and we had the first problem. We wanted to analyze the effect for PM 2.5. We chose that pollutants because of all the information we have inside the city, and because we know it is a priority pollutant, and it is a very important pollutant for our city. That's the reason we chose that pollutant, the fine particulate matter. And even though we have 5 monitor studies, we didn't have enough data for have a mean in PM 2.5 for that year 2022. So we chose just one station. Maybe in the years that we are going to apply this tool again, we could have more information or another station. So the exposed population was estimated in 1,312,000 inhabitants, and we chose the 25 years or older, or even the 30 years old, depending on the information the tool was required. So this study represents one of the first health risk assessments conducted at the district level in the city in our study case. And in Barranquilla, the average annual concentration, as just say to you, is 14.78 micrograms per meter cubes for that year. And when we compare in the first part of the study case with the WHO guidelines, we estimated using the tool that will prevent approximately 518 deaths per year, including these diseases, or 75 deaths per 100 inhabitants. So the second part of the study case, we wanted to compare how the air pollution or the air quality was improved, how the air pollution was reduced since 2018. Why 2018? Because it was the first year when we have enough data to analyze. Before 2018, we didn't have air quality stations, so we cannot have a good information before 2017. That's the reason we began in 2018. And compare the reduction of 2018 versus 2022, we estimated using this tool that they have 121 deaths per year across the study area prevented because of that reduction. So that information was very important for the local authorities. We give a number, we give even an economic assessment of that number, and they have enough information to continue all the urban strategies they are doing right now. So these are the main or principal urban strategy that the city has integrated health, climate, and environmental criteria into major urban development projects. The most important one, as you can see here in this picture, is the Gran Malecón. This is a 5-kilometer river work along the Magdalena River. It's a very huge river, so it attracts over 10 million visitors annually. They promote physical activity, recreations, and of course emission reduction because people use another type of transportation here, and because we have a lot of trees and park, as you can see in the picture. The another project, I don't have a picture of that, is the Todos al Parque, is a restoration of 285 public spaces into parks, adding a lot of green areas and giving 93% of the residents access to a park within an 8-minute walk. The another park is the Ciénaga de Mallorquín. As you can see here, this is the most recent one. Is a wetland with a 5-kilometer pedestrian and transit pathways. And finally, but not less important, is the Siembra program. It is a conversion of hard urban surface into green areas. Planting and maintaining those trees is very difficult here, was because you can see it by the location of our city. It is very hot. It's a tropical city. We don't have enough rain. So this is a very important project to maintain those outdoor spaces and recreation with those green areas. The another tool we use in our study case is the WHO tool HEAT. We use the HEAT tool. The HEAT tool calculate the premature death avoided by using physical activity in the form of transportation. So we had one problem with this HEAT tool, is that the local authority, the local government didn't have enough information. So here the academia was very helpful because we had that information. We had, because of our research, of our study, the information needed to apply this tool. So we had the result of annual premature death, the carbon dioxide equivalent, and the economic values estimated to be avoided annually due to current levels of active transportation in the city of Barranquilla. So we analyzed that impact, and we know they have a great risk. We had the risk of exposure to PM 2.5. We had the risk of fatal accidents, that was like 18. But when weighing the benefits against the risk of that physical activity, even though we have an air pollution problem, we don't have a good air quality maybe compared with other cities, we have a good air quality, but comparing with the guidelines, we don't have a good air quality. And as we just know, there's no safe levels, but comparing and weighting those benefits against risk, we analyze that the active transport in the city of Barranquilla provides benefits that are 6 times greater than its associated risks. So that information was very important to the city to improve the city, to do more strategies to improve the physical activity or use this active transport inside the city of Barranquilla. And finally, but not less important, we analyze the land use. When we analyze the land use, we analyze commercial density, walkability in the traffic characteristics, and we observe that in urban areas with higher walkability or pedestrian-friendly built environments, we have reduced air pollution, in this case, NO2. And those areas that we have the higher concentration of NO2, where the more vulnerable people that are the lower socioeconomic status that we have here in Colombia, socioeconomic status when we cannot because of the DANE that give us those information. So we obtained that the highest concentration were found in the southern part, where heavy traffic is more frequent, and the model suggests that more walkable areas have better air quality than other part of the study area. Promoting more sustainable transport can prioritize active modes such as walking and cycling that develop healthier cities. So finally, to conclude, the collaboration with other sectors is very important. We know that academia can provide scientific data, academic research, but the collaboration between the Barranquilla City Management, the PAHO, and the WHO can train all the people inside and give all the information they don't have. So the lesson learned is that we need to create a cooperative setting between health and environmental sectors and include other key stakeholders. I am from the environmental sector and I know many information, but maybe I don't know the health information. So the promote identification of health and climate gain of city information is very important. We need to engage with academic and technical cooperation entity in order to gain greater buy-in from the community to others than just talking about health or just talking about environmental. We need to integrate those social, environmental, recreational benefit, health benefits into this project and highlight that a cross-sectoral cooperation between those institutions can have advanceable, sustainable urban development. Thank you, Marianne.
Thank you, Professor Diana. So we would have our final case study. So now we have to think of doing more cycling to exercise our bodies and also joining public transport to reduce the pollution. So we have Professor Sumi Meha, who is the Vice President of the Environmental and Climate Health at Vital Strategies. Thank you so much, Dr. Sumi, for coming. We shall now listen to your case study. Kindly put your questions in the Q&A section so we do it after this case study. Thank you.
Hi, good morning, good afternoon, and good evening, depending on where this webinar finds you. Can I go ahead and share my slides? Let's see. Okay, are these visible?
Yes, it is.
Okay, great. So I'm gonna change gears a little bit. I mean, I think one of the things as we're thinking about this is, of course, the speakers already have demonstrated the real impacts and the real need to really use data. At the end of the day, we need to be able to quantify the impact of clean air actions and climate actions that are being taken, either through health impact assessments or other types of evaluation tools. At the same time, I'm going to give just kind of a briefer case study today that's just going to give some examples from the work that we have really the privilege of collaborating in India to work on some of this related to this. But just to give you a background, because I am actually an epidemiologist and an exposure scientist by training, but I'm actually working at the moment leading the environmental and climate health team at Vital Strategies, which is really a global health organization. So where we can really take a data-driven approach to focusing on leading risk factors and determinants of health. And you can see here we're really present in over 80 countries around the world and focusing on different areas, but really helping to strengthen government systems to address, particularly in low and middle income countries, to really address these leading determinants of health. So, today I'm going to try to focus in on what we are doing really as we bridge technical data, implementation, and policy to bring both air quality and climate into public health practice. And I think you've already heard a hint from the earlier speakers about sometimes what's a bit of a gap between the kind of the air quality side of things and the public health sector, similar with kind of climate and health as well. What we're doing here that I'm going to talk about is not so much the work that we need to bring kind of health into air quality management systems, which you heard quite a bit about with respect to some of the work around low emission zones and things like that, but really what can we do to bring these environmental determinants of health into public health practice? And so this is going to really entail a couple of different things. One is really to think about how you can identify and address some of the key evidence or capacity gaps that we may need to think about. So, for example, if we want to work on emerging concerns like heat-related illness, do we really have enough capacity and ability to collect data on heat-related illness at the local level? Thinking about how we can prioritize some of these intervention areas given the competing public health priorities that we may face. Related to that, how do we engage with policymakers to ensure their influence, their commitment, which is really needed for ensuring sustainability? And finally, what kind of communications activities are really necessary in order to ensure effective risk communication to be able to see our benefits at scale? So just to emphasize, what I'm talking about here today is really the fact that we need to work within the public health space, but we know that clinical solutions are often very limited, right? So, it's one thing to say, what do we do once the patient's already sick? But I think consistent with our kind of perspective within public health, what can we really do upstream to really think about public health harm reduction that can occur through climate action and air quality management, really focusing on regulations, on emissions from leading sources, what measures can be really taken to reduce risk of air pollution as well as extreme temperature, and then what can we do to really reduce exposures and impacts at the community and population level as well. Okay. And so we've been doing a range of work. I'm just going to give you a quick highlight before going into India, but just so that you can see that this is just one case study. There could have been many that I could have picked, but I've just chosen to kind of focus and do a deep dive in one today. It's been really important. We've seen a real increasing appetite for looking at more kind of data visualization so we can have better integration of the environment and climate data with the health data so that this can be used internally for decision making, but also externally for civil society and for the general public to communicate about different trends in environmental determinants as well as their impacts. A lot of this work has been done so far in China at the provincial level and then also in Brazil. Some of the work that we've done on more policy-related work is really thinking about how we can accelerate policy development and implementation. This work is underway in India, Indonesia, as well as in Ethiopia. And finally, I think, because we really want to think about using evidence to inform policies and activities, the increasing interest that we see on urban air quality survey, increasing the availability of data on air quality or heat-related illness in some cases in a range of cities around the world. So the case study that I'm going to share here is really the work that we've had the pleasure of being involved with India's national program on climate change and human health, which is through their NCDC there and their Centers for Disease Control in India. And this involves a range of different activities, everything from support of technical guidelines development, capacity building, particularly for the workforce, generating awareness among the public as well, strengthening surveillance that I'll talk about for air pollution and heat-related illness, and also how we can generate more data in general to be able to do the types of impact assessments which are really needed. This work has currently focused at two kind of levels. One is at the central or national level, which really includes the development and delivery of tools and playbooks and toolkits that can be used as kind of a public good to support implementation efforts more broadly, as well as technical convenings to help prioritize implementation efforts. And we'll also come back to this issue of, what do we really need to do to see the scale that we would like to see on the work. And at the state level, we're currently working in two states, Madhya Pradesh and Bihar. So I think most of you on this webinar are probably quite sensitive to the fact that air pollution is a leading cause of death around the world. India is also particularly effective here. More than 2 million deaths occurring that can be attributed to air pollution every year. And this actually accounts for around 18% of all the deaths in India that can be caused by air pollution. So there's a lot of work underway and commitments under India's national program on climate change and human health, which really accompanies and also extends the work through their national clean air program. But this is really the health sector response to focusing on air pollution. And one of the things that's been really interesting to work with here is, as this is something relatively new in terms of from an implementation perspective, there's been a lot of work to say, what do we need to do to strengthen the health sector's preparedness, and there's now a mandate for health workers to also play a role in promoting clean air for health. But the challenge is, okay, how do we do this? There are many different cadres of health workers, and so we're working right now to really develop tailorized custom training materials for the range of health cadres, whether it's medical officers, whether it's community health workers. In some cases, there's an interest in school children as well, state and district nodal officers, as well as accredited social health activists or ASHAs. And I'm going to give you a little bit more detail on that example now. And what each of these different health cadres have actually a different role to play in how they actually come into contact with and are able to either communicate, raise awareness, sensitize populations, or collect data that are needed. So ASHAs are really the frontline health workers in India who play a key role in raising community awareness. So those of you who are not familiar, these are very similar to like the extension workers in Ethiopia. Many countries also have similar parallels, but these are really the people who act as a direct bridge between the community and the health system. They often focus on maternal and child health related issues, so they have strong community ties and are very much in touch within their own communities with knowing who are the most vulnerable populations, including women, children, older people, and people with pre-existing medical illnesses. And I know somebody had mentioned in the chat, it's really important as we're doing this work to raise awareness not only about respiratory disease, which people are kind of now more aware of, but also the important link between air pollution and cardiovascular illness as well. So this is something that's been a big priority to kind of change the perceptions and the awareness around. And so one of the challenges is, okay, ASHAs are extremely busy, but so how can we work to better integrate the information on awareness and guidance as well to their ongoing activities related to household visits or other community platforms so that they can do this in a way that is already kind of streamlined or mainstreamed into the work that they have. So just to give you an idea, we train them to share accurate information about air pollution, its leading causes, whether you're looking at urban or rural areas, as well as the health effects. And so you can see here just an example of, highlighting the different types of sources of pollution from the ASHA handbook that people may experience depending on where they live. And then we think about how to equip them to have contextualized messages that are specific to the needs of the community. So you can see here the different kinds of guidance. This is, of course, in English, so that you can read it, but it's available in different languages. What can you do to protect the general public in terms of sources? What can you do to protect your family, but also vulnerable populations? And we give them specific examples of where and how they can integrate air pollution into their routine practice. So what can they do when they're going for village health days? What can they do when they're working one-on-one with individuals? What are the opportunities to sensitize people about air quality and its impacts when they're working in small groups, for example? In addition, there is a lot of work underway for them to have the types of information education and communication materials, which are initially developed in Hindi and in English, and then adapted to local languages. And so you can see a few examples of the work that has come out here in terms of some of the guidance that they provide to ask people to protect their health from air pollution. But the challenge that I wanted to emphasize here is that there is a concern that a lot of these recommendations end up being kind of for individual actions that are being taken, whereas we know that what we really need to promote longer sustainable solutions is really the type of awareness raising and public demand for policies that will really impact at scale. So just to give you another idea of this is, last year when they had some of the air quality days, again, you can see here that there's a lot of the recommendations here are really focused in on individuals and what they need to do. So we're also thinking about what we can do to raise awareness more broadly, to think about kind of sustained policy change. Here you see some examples of kind of engaging youth to be advocates for clean air. This often happens around key moments like World Environment Day, World Clean Air Day, or in India, National Pollution Control Day, where we're really trying to raise awareness and get the youth also involved in thinking about some of these things. But again, the biggest priority as we do this is to really think about what we can do to bring these things to scale. So when we're talking about training ASHAs, as vital strategies, there's only a limited number of people that we can train on an individual basis to be able to do this at scale. So we take actually a train the trainer approach so that we can really orient some of the key people that we need, whether it's epidemiologists, program managers, or nodal officers, to really better strengthen climate and health program data and reporting. So you can see some examples here from some of the different trainings that have happened over the past couple of years. And these often happen in support with high-level local leadership. You can see actually on this top left corner, the gentleman in the blue shirt is actually the head of health. He was the head of health at the time for the city's municipal corporation, and so very influential in making sure that this issue got the kind of attention and commitment that was needed. And so, this work, it really is critical. Here's an example of the guidance on strengthening surveillance for heat-related illness and air pollution-related illness, which is really needed so that the Sentinel sites actually know why they have to collect this kind of information, what value it has, so that we get more complete data to be able to evaluate impacts. So finally, I just wanted to show you, as I mentioned, we really think about working at scale. The reason why we adopt the train the trainer approach, and just to get an idea of the potential impact you can have, when we're looking, and this is an example that we've worked up for the 6 different states where we've been working over time, and you can see that if you look at a train the trainer approach, starting from having just 6 nodal officers, they would then go back and train 179 district nodal officers, who would then be responsible to extending the training to all of the ashas within the areas that they're responsible for. And eventually, with those 6 nodal officers, you would be able to kind of cascade up to reach over 60 million households. So, this is the type of thing that we really need to think about as we're thinking about really integrating air pollution or heat-related illness into being really sustained issues that are taken up by health systems that already have a lot of competing priorities that they need to deal with. So I think in the interest of time, I'll end there. Thank you very much for listening.
Thank you so much, Dr. Sumi. It's been a very insightful presentation from all our speakers. Due to limited time, we will take one major question to all the speakers. So we would have Professor Leon first, followed by Professor Tariq, Professor Diana, and Dr. Sumi. So the question to the speakers is, given the growing health impact of global climate change, what key strategies should be taught to public health students, drawing from your experience, to help them prevent, manage, and adapt to climate-related air pollution within public health systems? So we would have Professor Gio giving us her view on that. Please, you are muted.
Sorry. Yeah, this is the most important question, and I think it's very, very important for the policy makers to be informed of the potential health outcomes by the air pollution as well as climate change. And some of the questions remain open as to what have been efficient in reducing the impact of health from the air pollutants and from climate change, especially climate change. We are a little more aware of the climate effect on health, but less informed on the climate change effects. So I think that need to be developed, and the policymakers need to be convinced that such efforts will return results, and that they need to be calculated into the, for example, health insurance savings and things like that. So I'm thinking probably the efficiency in intervention need to be summarized, or so the data need to be collected together, so people can have a more informed decisions, more informed strategies. Thank you.
Thank you, Prof. We shall have Professor Tariq.
Okay, so that's a very broad question. I would probably just focus, if there is one takeaway that I think I would like to emphasize, is really the importance of considering that different communities, different subgroups in a population are more impacted, less responsible and more impacted, and also less resilient. So just to highlight the environmental justice implication of everything we talked about today, and probably in the last and next weeks of this specific class, and emphasizing the fact that there is like differential exposure. So for different reasons that could be described, some communities are going to be systematically more exposed to air pollution because of the kind of landscape or because of land management more generally. And that could be explained by centuries or decades and centuries of processes. Then there will be the differential susceptibility, which because some individuals may have a specific job, may not have access to healthcare, may live in specific material conditions. So they may be more susceptible to the impact of climate sensitive exposure, more generally, including air pollution. And also differential adaptive capacity, because we talked about some solutions today, but it's not because we provide access to some resources that people that need this type of resources the most are going to benefit from them. So when we think about all of this kind of spectrum of reasons for which we see these inequalities that are driven and exacerbated in the context of climate change, I think this is important. So if there is one takeaway message, that I would pick this one today.
Thank you, Professor Diana.
I don't know what to tell. They just talk about everything. Okay, but I just want to answer as a professor here, and the information is very important. I think the courses are very important. I think we need more courses like this. I think every area needs to stay informed, not just the health area, not just the environmental areas, but everyone needs to be informed. And we need to give more information from academia. I see that people doesn't know that that was Professor Tariq telling, or Professor Leon was talking about. We don't have that information. Everyone doesn't have that information. They don't know because air pollution and climate change, you cannot see that. You don't know the effects. And I think we need more courses. I think we need to give this information to everyone, not just us, but give that information out there.
Thank you, Dr. Sumi.
Sure. So I maybe just wanted to amplify the message that onto Dr. Benmarnia has given, which is that we know that there are a lot of inequities associated with exposure to air pollution. As I think as we're thinking about how we prioritize the most important solutions, we should think about really those which are going to reduce these inequities, which, of course, occur globally, but even at a local level, depending on what you choose, it's really important to think about, how we can really reduce exposures for those who are already taking a greater burden of this. For all of the solutions that we have for for every leading source, we know that the solutions are available, but they're not always equally accessible. So I think that, we need to just make sure that we keep our eye on the prize of really kind of reducing the inequities as we're thinking about which actions we choose to focus in on.
Thank you so much, everyone, for your time. So as participants, we are supposed to spread the word. Let's share everything we've learned here with everyone so we can help reduce the impact of climate change. Thank you all for joining today. Our next section will be on climate change and vector-borne diseases, emerging risks and intensification threats. I'm Marianne Ofer, the coordinator for the Association of Schools of Public Health in Africa. Thank you once again and enjoy the rest of the day.